Hi everyone. It is Wednesday night, 7:30 p.m. We are starting our fifth journal club, and I am just waiting for Dr. Messamore to join us. He is going to be presenting our article tonight for our journal club, which is exciting. Let me just see if we can get him on. Okay. Hi, Radhika. Hi, Eric. So I just tried to add you. So it says adding right now. And oh, there we are. Hi, how's it going?
Good, thanks. How are you?
Good. And welcome back. So for those of you who either are newer to the group or maybe missed the first video, Eric Messamore, who's presenting today, he actually did a video for us way back in, I want to say January, February of this year, of 2018. And back then he did a video on the neurophysiologic subtypes of schizophrenia, which was really cool. Okay, so I'm going to read you guys his biography, and then we are going to get started. So Eric Messamore earned his PhD in pharmacology from Southern Illinois University in Springfield and completed a postdoctoral research fellowship at the Karolinska Institute in Stockholm. He went to medical school at the University of Illinois in Chicago and then trained as a psychiatry resident at Oregon Health and Science University in Portland. He is currently an associate professor of psychiatry at Northeast Ohio Medical University near Cleveland, and he serves as the medical director of the university's Best Practices in Schizophrenia Treatment Center. He conducts research about the skin flush response to niacin, which is abnormal in schizophrenia, and may serve as a useful biomarker for schizophrenia genetics or possibly as a tool in a personalized medicine approach to treatment. Dr. Messamore says that he became a psychiatrist partly because it's a natural fit for someone with a PhD in neuropharmacology, but mostly because he likes to see people get better, and opportunities in psychiatry to help people get better are numerous, and the magnitudes of those improvements can be substantial. He's been a member of Psychiatry Network since February of 2016 and enjoys learning from the experience of others. So thank you, Dr. Messamore, and welcome, and take it away.
Yeah, well, thanks, Christina,
Yeah.
and it's a great pleasure to be with all you guys this evening. I've been asked to do something like a journal club presentation, and the paper that we're going to discuss is called Efficacy and Safety of Antidepressants Added to Antipsychotics for Schizophrenia, a Systematic Review and Meta-Analysis, and the author is Bartosz Helfer and colleagues. As the title implies, this is a review and a meta-analysis which considers the use of antidepressants co-prescribed with antipsychotic medications among people with schizophrenia. This meta-analysis addresses two key questions. The first question is, to what extent do co-prescribed antidepressants in this population address clinical symptoms such as depression, negative symptoms, positive symptoms, and quality of life? And the second key question is essentially, is this safe? To what extent might the co-prescription of antidepressant medications with antipsychotics in people with schizophrenia be associated with a change in the occurrence of adverse events? The overall question of antidepressant pharmacotherapy in schizophrenia is important for several reasons. First, there is substantial overlap in symptoms between the two conditions. I'll explain that momentarily. In addition to clinical symptom overlap, there's also emerging evidence from genetics that there's substantial genetic overlap between major depressive disorder and schizophrenia. And finally, there's just frank comorbidity. Depression or significant depression meriting major depressive disorder diagnosis co-occurs with schizophrenia with frequency. The author actually cites a modal prevalence of co-occurrence of about 25% over the two conditions. So talking about some of the specifics over the overlap, symptom overlap. If you do interviews, structured clinical interviews to try to rate negative symptoms as a researcher, you'll find, as I did when I started doing this, there's really it's a little bit baffling because you'll ask people, do you lack motivation? Do you find that your range of emotional experience is subdued? Do you not experience pleasure? Do you find that you're not motivated to get out and engage in social activities and so forth? And many of these questions, I mean, to a psychiatrist's ear, are very reminiscent of the things you hear in people with major depressive disorder or in dysthymic disorder. The only major things lacking between the two diagnoses are a sense of worthlessness, but actually many people with schizophrenia have that by virtue of the stigma of the illness, and thoughts about death and suicide. So there's some differences, but there's also significant overlap in clinical symptom expression. Genetics. There's a thing called the polygene. If you haven't heard about it yet, you will hear about it one of these days soon. The latest and largest of the genome-wide association studies reveal about 108 genes with significant association with schizophrenia. So many genes, hence polygene. It turns out about 40% of those genes in the schizophrenia polygene are associated with risk for depressive disorders as well. So significant overlap in genetics. And as we mentioned, there's the outright comorbidity. The authors cite research that gives a range of estimates of comorbid depression and schizophrenia, but they cite a modal prevalence rate of 25%. 25%, 1 in 4 people, is quite a significant number. Despite the significance of all these things, and clinical significance of depression and schizophrenia is also accentuated by the fact that people with depression and schizophrenia will have poor overall outcomes, will have more frequent relapses, and higher rates of suicide. So despite all of those considerations, there's actually not a whole lot in the way of well-designed, large-scale, systematic studies. So the authors then resorted to the technique of meta-analysis, in which they tried to identify every paper that addressed addressed antidepressant pharmacotherapy in people taking antipsychotic medications with schizophrenia. They, in the end, out of some 10,000 initial citations that they found, they found 82 that were randomized clinical trials with a comparison group, either a placebo or a treatment as usual comparison. And with each of those studies, they tried to then look at the effect of antidepressants. In a meta-analysis, recall, that's the basic technique of meta-analysis. Get a lot of studies, try to look for the effect of the intervention, and then lump all those effects into a big table and tabulate it. You, of course, will find some people will use, they'll use different rating scales. Some people will use Montgomery-Åsberg, some people will use Beck, some people will use Hamilton. And of course, there are different drugs that are studied. So the question is, how do you compare reasonably all these different studies when the outcome measures may be different? So to normalize this, authors of meta-analysis will use effect size. They will say, take the difference between the comparison condition and the treatment condition, measure that, and then divide it by the amount of variation on both sides to try to normalize the degree of spread. When you do this, you can get something like you get a statistic that allows you to compare, if you will, apples and oranges. So they tabulated effect sizes of the various studies, and again, asked the questions: to what extent does treatment impact clinical symptoms, and does it look safe? For those of you who have the paper, you can take a look at Figure 2. And for those of you who don't have the paper, I will just explain it. Essentially, antidepressant co-prescription with antipsychotic drugs for people with depression and depressive symptoms seems to be effective. It seems to be almost across the board, certainly across the board for the outcome measures that they chose, which were depressive symptoms, negative symptoms, positive symptoms, overall symptoms, and quality of life. Every one of those domains showed improvement with antidepressant pharmacotherapy. The magnitude of the improvement was modest. The effect sizes range between 0.2 to 0.3. There wasn't any overlap of the confidence intervals with, the confidence intervals of these estimates did not cross 0. So they were statistically significant changes. And the effect was, as I said, moderate, or moderate to slight, but nonetheless significant. Moving on to primary outcomes, I'm going to talk about some subtypes of the analysis in a second, but just to go on with primary measures. They found across the board improvements in those symptom domains. They also found that, if you will, the most concerning possible adverse effects, neurologic side effects such as exacerbation of EPS or akathisia or involuntary movements or frank exacerbation of psychosis, none of those adverse events happened with any greater frequency in the antidepressant treatment group than in the comparison groups. So one of the historic concerns about antidepressant co-prescription is that it might somehow worsen psychiatric outcomes, especially exacerbating psychosis. They didn't find a signal for that. They went through a very large list of standard side effects, and essentially none of them showed higher prevalence in antidepressant co-prescribed pharmacotherapy, with the exception of abdominal pain, some GI symptoms, abdominal pain and constipation, dry mouth and dizziness. Those were really the only signals that stood out. And the effect size of those, well, I mean, the risk ratio is about 1.8. So the likelihood that you're going to have one of the side effects is about, well, the ratio is 1.8 to 1. So it's essentially an 80% increased likelihood of one of those side effects that I mentioned. So the bottom, I mean, to summarize the primary outcomes, they seem to be clinically effective at reducing symptoms that we would care about. And with the exception of some GI symptoms, dizziness and dry mouth, not really creating significant adverse event burden. They did some interesting analysis of subgroups. So they took, amongst all the individuals that they could identify from the pooled clinical studies, they pulled out the ones that were predominantly depressed and predominantly with negative symptoms. So the patient subgroups with more severe depressive symptoms and with more severe negative symptoms were pulled out. And actually then in those subgroups, you find that the antidepressant therapeutic effects were stronger. The effect sizes went from 0.2 to 0.3 to around 0.3 to 0.5. And when we get into the 0.4 to 0.5 effect size range, that is on par with the effect size of antipsychotic medications for the treatment of psychosis, or on par with the effect size of antidepressant medications for the treatment of depression. So in those subgroups with stronger negative symptoms or stronger depressive symptoms, antidepressant pharmacotherapy was more significantly effective. Notably, it addressed both negative symptoms and depressive symptoms. Those were the biggest benefits of antidepressant co-prescriptions. For those of you who have the paper, those subgroup analyses are listed in Figure 3. And yeah, the last figure I'll draw your attention to, because this question I'm sure comes up, it was one of the first questions in my mind. Figure 4 in the study lists each of the different drugs. So again, they had 82 papers with a whole bunch of different medications which were studied, and they asked the question, you know, can we pull out the effect size of MAO inhibitors or of SSRIs or of tricyclics? They did that, and the effect sizes for some drugs looked really quite impressive with effect sizes of 0.6 to 0.7. But the major caveat is that the number of trials that were summarized to get those meta-analytic results and the number of participants involved was pretty small. So the numbers are tantalizing. For example, I think if you look at the top part or the top half of Figure 4, you'll see that trazodone has an effect size of about 1. So it makes me think, wow, I should prescribe trazodone as my co-prescribed antidepressant. But that's based upon one clinical trial with 60 participants. So hold your horses on making decisions on specific medications based upon the table. But nonetheless, it's interesting to see. And so those are my comments on the paper. Overall, this is a pretty straightforward study about an important question. That question being, are antidepressants co-prescribed with antipsychotics in people with schizophrenia effective for depressive symptoms or for negative symptoms? And the answer is yes. And they seem to be more effective when, and the effect size seems to be more pronounced when those medicines are given to people with more pronounced depressive or negative symptoms. And the second question is safe, and the safety data look very good with only the GI complaints showing up. So to summarize again, the summarized main points: depression and schizophrenia is a major problem. Frank comorbidity, the co-occurrence of those two diagnoses, is estimated to be about 25%. Antidepressant co-prescription results in improvements in positive symptoms, negative symptoms, overall symptoms, and depressive symptoms, as well as overall quality of life. And in terms of adverse effects in this meta-analysis, only the GI disturbances, dizziness, and dry mouth showed up as a signal. So I was asked if I could do this in about 15 minutes, and I see that I did. So we
Great
can
timing.
open it up for questions and discussion.
Yeah, there was one question which you alluded to that said, curious how they differentiated between depression and negative symptoms of schizophrenia in regards to outcome.
Yeah, well, as I said in my introduction, it's a kind of devilish question because there's a significant degree of overlap between some of the vegetative symptoms of depression and some of the negative symptoms. The authors actually, from my personal view, I give them credit because they took a very broad approach. I don't think the authors, if they were here, would say that they sweated a lot about the difference. They would take negative symptoms or depressive symptoms kind of at the word of the authors, or to the extent that they described instruments that they would do this. But it was a very, if you will, naturalistic study. I mean, they looked at if the study authors said it was significant in terms of depressive or negative symptoms, it was included. So to answer the question more directly, they didn't really sweat on the fine points of those distinctions. And actually, I mean, to the extent, to my point, that they look very similar clinically, you see similar effect sizes both on the depressive symptoms and on the negative symptoms in the effect size tables that they show.
Thank you for answering that. And the only question that I have is there anything that you would do differently going forward in your practice based on this article?
Me personally, in my practice, I don't think I would do much differently because I learned from state hospital days that antidepressants seem to be quite helpful for the patients with a very profound negative symptom syndrome. I mean, my experience with the use of antidepressants in this population is that it takes a while for them to work. I mean, we have the clinical trial data from antidepressant use says that it should take 4 to 8 weeks. And I would say, you know, for sure, 8 weeks to 12 weeks, perhaps, in a schizophrenia pharmacotherapy trial. So I'm a big fan for trying to screen for those symptoms as well as for offering antidepressants to people that have either a negative symptom syndrome or depressive symptoms. And just one other comment on the addressing negative symptoms. We get, and because I think our training and a lot of our practice settings sort of force us into this, we get really focused on pharmacotherapeutic solutions to negative symptoms. Where you see the really biggest effect sizes on negative symptom improvement are with some behavioral or psychological interventions, something that in depression world we would call behavioral activation. I don't know how that's translated or what term they use for schizophrenia care, but essentially getting people to be moving a little bit or finding something that may marginally interest somebody and having them follow that. So gradually re-engagement with the world, and as I say, the deliberate cultivation of positive experience over time can do a really, really impressive amount of improvements. So finding something that they used to like or that they might like and figuring out ways to encourage. And I can, you know, I'll give an anecdote that
Sure.
illustrates this. Not my patient, but a colleague of mine was talking about how he had struggled mightily with this patient in his clinic, and he tried everything several times. Well, a couple of things he tried a couple of times, but it was a lot of both positive and negative symptoms in this individual. And then what happened was that there was a talent show in the city, and the talent show was for challenge among people with severe mental illness. So the case manager of this patient said, "Dear patient, I know you like singing. You should do this." And with a great deal of encouragement from the case manager, the patient enrolled in this talent contest and got lots of positive feedback from people she knew, people she didn't know, people who worked with her. And to paraphrase a psychiatrist, in like 5 years of trying, nothing I did could even come close to what that one case manager did with finding something that the patient had an affinity for and getting her to go into it. So pharmacotherapy is useful for sure, but I think we are at risk of losing sight of some very substantial gains that can be made through wise psychosocial interventions in the negative symptom space.
Absolutely agree with that. And I'm glad you mentioned that. Actually, Eric is going to be back next Wednesday, presenting another topic that sort of touches on the socio-developmental cognitive model. So we're going to look forward to that. That's on Wednesday. And next Monday, we have Elise Rosenberg also presenting on first episode psychosis. So with that, we are finished up. I did update. I know that there's been some issues with the links that I've posted. So the link that we have up is the correct link at this point going forward. I apologize for the confusion. I had like 5 different links that I was posting for the CME. The CME questions for tonight's article will be posted first thing in the morning. I don't believe that they're up quite yet, but after tomorrow morning, they'll be up, and you can claim your CME for the next 12 months after watching. Well, 12 months from today. So thanks, everyone. And anything, I'll say bye. I don't know if you have anything to say, Eric.
No, I think I've talked a lot.
Okay.
So thanks for the questions.
Yeah,
It's great to talk with all you again, and I look forward to coming here next week and talking
wonderful.
about the next
All
paper.
right.
All
See you
right,
guys next week. Bye.
take
Take care.
take care,
Bye.
folks.